And today we have Dr. Julia Henry with us. She's a pediatric neurologist at Comer Children's Hospital in Chicago. And she's also on our medical advisory board. And today she's going to be joining us to talk about epilepsy and learning. And so she'll go through her slides, and then if you have any questions, feel free to put them in the chat, or we can answer them after she speaks. So with that, I will turn it over to you, Dr. Henry. You can share your screen.
All right. Okay. So Aisha, thank you for the introduction. Today I'll be talking about epilepsy and learning, and then so I'll go through some slides, and then we'll have some time at the end for Q&A. So again, thanks to the Epilepsy Foundation of Greater Chicago for inviting me to host this virtual chat. And so we'll get on with it. Let's see. So I wanted to talk about how epilepsy affects learning, how epilepsy treatment affects learning, what learning problems we commonly see with epilepsy, how to get tested for learning problems, how to help your student with epilepsy reach their potential and get the most out of their education, how to manage seizures in school, because that also plays a big part in your learning. And so we'll start with how epilepsy affects learning, and then how epilepsy treatment can affect learning. So the way I think of it, epilepsy is not just a condition by itself that exists in a vacuum. There's usually an underlying cause for most people. And sometimes we know the cause. We know it's maybe some scar tissue from a stroke, or it's a genetic abnormality, or sometimes it's something that runs in the family. And so the underlying condition causes the epilepsy. And that underlying condition may also cause some developmental delays or learning problems. And then there's also a small contribution from the epilepsy itself to the developmental delays or the learning problems. But there's a certain subset of epilepsy where you have the underlying condition that causes the epilepsy. And it's really the epilepsy and the seizures themselves that cause the developmental delays and the learning problems, with a smaller contribution to the developmental delays and the learning problems coming from the underlying condition. So an example of the first type, where it's really the underlying condition and not so much the epilepsy itself causing the developmental delays or the learning problems, is called what we refer to as an epileptogenic encephalopathy. So that's a really fancy term. So epileptogenic means that something else is causing the epilepsy, and encephalopathy means it's just a broad term for brain dysfunction. So some examples of this are prior insults or injuries like a stroke, history of meningitis or a traumatic brain injury that causes some scar tissue, cortical malformations or dysplasia, so cases where maybe a part of the brain didn't form quite right and predisposes the person to have seizures. And then many other genetic conditions, just for example, trisomy 21, Rett syndrome, Angelman syndrome, and then various causes of autism can be these epileptogenic encephalopathies. And so an example of that is a case, so I've got a first grader who has a history of stroke in the newborn period that affected the left side of her brain. So because of this stroke, she has epilepsy and had intractable seizures. She had weakness and spasticity or stiffness on the right side of her body. She had a vision impairment on the right side, speech delay, and learning disabilities. And because the seizures couldn't be controlled with medication alone, and because we know that children in her situation often do really well with epilepsy surgery, we did an epilepsy surgery to disconnect the left side of her brain from the right. And that actually cured her seizures, but she continued to have some speech delay. She continues to have the motor impairments. And over on the right is just an example of what it looks like when somebody has a large area of scar tissue over here. This is some empty space, and what we're looking at with these bright colors is the white matter connections. And so it shows us how the different areas of the brain are connected and communicating with each other. So this is the frontal lobe, this is the right side, the left side, the occipital lobe or the back of the brain where we process vision. For most people, language is over here on the left frontal lobe, but in this child, this area was completely, disconnected from the rest of the brain. and then on the other hand, we have those epilepsies where it's the epilepsy itself, it's the seizures itself that are causing the developmental delays and the learning problems. And maybe there's a small contribution from the underlying condition, but it's mostly the epilepsy that's driving the neurocognitive problems. But as grim as that may sound, the upside of this is that treating the epilepsy can result in significant improvements in learning and development. And so some classic examples of this where intervening early and controlling the seizures can change the developmental trajectory include infantile spasms. So those are seizures that occur almost exclusively in infants in the first year of life. And it looks like just a little flexion or a little head nod, and they come in clusters throughout the day. And often there's a period of plateau in an infant's development right before the seizures start or right at the same time the seizures start. And the seizures themselves may not look that alarming. And so sometimes there's a delay to treatment or delay to diagnosis because it's not like what people think of as seizures with full-blown convulsions. But we've known for a long time that infantile spasms are strongly associated with developmental delays. And in the older literature that described infants with infantile spasms said that only 20% end up having normal development after their infantile spasms. But over time, we've learned a lot, and we've learned how to treat them with the proper medications. And we know that intervening early as soon as you see the spasms start, or as soon as you make the diagnosis and getting them under control and into remission actually can result in normal development for a lot more babies who experience that condition. Some other epilepsy syndromes that fall in this category where it's an epileptic encephalopathy, the seizures themselves are causing the delays, are Lennox-Gastaut syndrome. And another classic example is electrographic status epilepticus of sleep. It's also known as Landau-Kleffner syndrome. This happens in children who seem to be developing normally, and they don't have any visible seizures. Parents, teachers, observers would have no idea that they're having seizures. But when they go to sleep, if you have the EEG on in their sleep, they have continuous spiking activity in their brain that disrupts the normal sleep background. And it's this continuing spiking activity in sleep that impairs their cognition and impairs their learning. And sometimes these children may even be misdiagnosed as having autism. So this is something we want to think about and look for when we're seeing toddlers and preschoolers who had normal development present with autism symptoms or speech regression. And the good news again here is that it usually responds well to treatment, and getting that spike activity and sleep under control can result in normalization of the development or any cognitive impairments that came along with the electrographic status epilepticus in sleep. Tuberous sclerosis is another interesting example. So tuberous sclerosis is a genetic condition that causes lots of benign growths in different parts of the body, most notably in the brain. And so these benign growths, also known as tubers, can cause seizures, and they can also cause impairments in the part of the brain where they're located. And so here you have the condition where both the underlying condition, the tubers, is causing some developmental delay. But we know that the seizures in children with tuberous sclerosis also significantly contribute to developmental problems, learning problems, and autistic behaviors. And so controlling those and getting a handle on them early in the course can really alter a child's developmental trajectory for the better. So here's another case of the example where the seizures themselves are causing the problem. So this is a first grader who had a history of autism. And when I saw him in clinic, he was seizure-free for 4 years, and he was only on a single medication. And we thought, well, great, well, maybe he can come off his seizure medication. He's been seizure-free for such a long time and is not on a very big dose of medication. So we got his EEG, and when I reviewed it here, when he was awake, I see nice continuous brainwave activity. I do see some abnormalities. Here's a spike here, but a spike's not necessarily a deal breaker for weaning off seizure medications. But then he fell asleep, and we saw a big red flag in his EEG. And what we're seeing here in the sleep EEG is the spikes are kind of bigger and more dramatic, which is concerning. But the most concerning thing is here where this yellow highlight is, we see the brainwave activity that's coming along suddenly kind of drop out for a good second and before it comes back and gets restarted. And we were seeing this over and over in his sleep. And it's kind of like the brain just getting interrupted or shutting down briefly on and off throughout sleep. And we know when we see that pattern, that's a sign that you may be dealing with an epileptic encephalopathy and that the seizures themselves may be causing the developmental delays. So we went over these results with his parents and decided to try a steroid pulse where we give a high dose of steroids. We can either do it by mouth or by through the IV. This has been shown in other case series and research studies to help treat the epileptic encephalopathy. And so after the child got the steroid pulse, he had a notable improvement in his language, his adaptive behaviors, and when we got the follow-up EEG, we saw much improved continuity of the background. It didn't totally cure it and make it go away, but it had a significant positive impact on the quality of life for the child and his family. Now, most childhood epilepsies will fall somewhere in between these two extremes, where the underlying condition causes the epilepsy, and both the underlying condition and the epilepsy are contributing to the developmental delays, learning problems, or memory problems. And we know this because sometimes, even when we get the seizures under control and somebody's been seizure-free or in remission, or even able to wean off their meds, some learning issues or developmental delays may persist. And then there are many children and people with epilepsy who have no developmental delays or learning problems or cognitive effects. So it's not all bad news. So how does medication affect learning in epilepsy? So it does so in a number of ways. So over here we have our kind of generic anti-seizure med, or ASM. So they can affect learning and cause some academic difficulties by impairing attention, causing sedation or sleepiness, making it difficult to stay awake and pay attention in school. It can cause mood changes, making it more difficult for a child to want to engage in school or to be distracted by, feelings of anxiety or depression. And it can slow processing speed. These things happen to varying degrees with different medications and in different children. So just to use topiramate, for example, the brand name is Topamax, and that's a relatively common medication. It has this nickname of Dopamax because it has this kind of notorious side effect of mental fogginess or cognitive slowing. Students and adults who take this medication may report feeling like slow or sluggish when they're trying to do cognitive work. But it doesn't happen to everybody. Some people take it and are just fine. So it's really depends on the individual medication and the individual patient taking the medication. The best way to tell if it is the medication is if you notice a significant change after starting the medication and it seems to be dose dependent. So the higher the dose, the more side effects you have. The lower the dose, the less side effects you have. Those things can be clues that it's the medication. And so it can be a really tangled web to untangle when you're trying to figure out why a child with epilepsy may be having learning problems or academic difficulties. As we talked about, there's the contribution from the underlying condition, there's a contribution from the epilepsy, and also some possible contribution from the anti-seizure medication. There have been studies that have looked at the contribution from anti-seizure medications, and it does seem that it's relatively small compared to the contribution from the epilepsy and the underlying condition. People with epilepsy often have mood or anxiety problems, and again, can be caused by all three of these factors and can impact learning and school performance. And the underlying condition and the epilepsy and the seizure meds can all negatively impact sleep, and sleep can of course affect your learning and your academic performance. And so when trying to address learning problems or academic problems in somebody with epilepsy, you have to look at all of these things and kind of untangle that web and kind of tinker away until you can figure out what the major contributing factors are and make adjustments. So what learning problems are commonly seen with epilepsy? So some of the most common ones are ADHD or problems with attention and concentration, short-term memory difficulties, specific learning disabilities like dyslexia or specific reading disability, or dyscalculia, which is a specific math disability, impaired processing speed, impaired executive function. So this is your planning and your organization. So directing what you do, keeping track of what you're supposed to do for class, keeping track of assignments, figuring out how to complete an assignment. Intellectual disability, so this is lower IQ. It affects kind of all areas of brain functioning. Depression and anxiety are common in epilepsy, and they can impair attention, concentration, executive function. They can also go back and impact sleep. So again, getting back to that tangled web, where sometimes it takes some time to sort out what is influencing the learning problems or the symptoms that we're seeing in the student. And then social isolation and bullying can sometimes come along with epilepsy. So that's also important to address in somebody who's struggling at school. Is there some, some social factors contributing? So if you suspect these things, how do you get tested for learning disabilities? And then how do we, once we have those test results, how do we help the student reach their potential? So there's school-based testing, and that's probably something that every parent should consider first, or caregiver should consider first when they're having some academic struggles, is going to the school and requesting testing from the school. There's also private testing in the community, and kind of the most comprehensive of this is neuropsychological testing. And then school accommodations come in kind of two big categories. There's 504 plans and individualized education plans. And so we'll go through each of these. So school-based testing can be done through the public school system, or you can also get independent educational evaluations. These may consist of a psychological evaluation, which looks at emotions, behavior, and social skills in the child's social functioning at school. And then there's psychoeducational testing, which focuses on the educational needs of the child, the basic IQ testing. It looks for learning differences, it looks for attention problems, and it looks at academic performance. And these are done by people who work within the school system, various professionals within the school system. Neuropsychological testing is a more comprehensive evaluation of brain functioning, learning differences, behavioral testing, and academics that occurs out in the community, and it is an independent evaluation. A neuropsychological evaluation can be quite lengthy. It takes anywhere from 4 to 8 hours and is sometimes broken up over multiple days for children who have difficulty sitting for that long. And it's a comprehensive evaluation of brain functions. And it looks at various components of brain functioning. So again, that executive functioning, the planning and organization. It looks at attention span and concentration. It looks at memory, short-term and long-term. It looks at language skills as well as nonverbal skills, including visual, spatial, motor, other sensory skills. It looks at processing speed, and it also looks at social and emotional well-being. And the results of these evaluations can be really helpful, both to the family, to the neurologist who's managing the epilepsy, and to the school for developing any plans or accommodations to help the child succeed. In addition to addressing any learning difficulties, learning differences in a child, you want to treat the contributing factors. And so this is something to take back to your neurologist or your pediatrician, and make sure that you've got the seizures under control as best as possible. Adjust those anti-seizure medications to limit any side effects. Work on good sleep hygiene and treat any sleep disorders. So things like sleep apnea, restless leg syndrome, that could be disrupting the quality of nighttime sleep. Treating anxiety and depression that can be interfering with functioning. And also there may be medical treatment of ADHD or even medical treatment of behavioral symptoms that can be helpful. So school-based plans, as you may be familiar with, there's individualized education plans and 504 plans. And so IEPs are come from this from the Individuals with Disabilities Education Act. These are both federal programs, so they're valid in all 50 states. Every state's required to have a process to set this up through the public school system. And IEPs are for children needing special education services. So this includes children with learning disabilities or ADHD, or who just learn differently. It requires testing at onset to show what the learning disabilities are, the ADHD is, or developmental delays are for that specific child. And then children are retested every 3 years. This involves a formal meeting. It's a multidisciplinary meeting where the parents and the guardians meet with the team from the school. So that may include general education teachers, special education teachers, therapists like a speech therapist, occupational therapist, maybe the guidance counselor, the school psychologist who did the testing. And during this meeting, they talk about the findings from the evaluation. They get the contribution from the parents or the caregivers and develop what sort of resources the child will need, what accommodations the child will need, what's the most appropriate setting for the child. And there's a standardized IEP document that gets filled out at these meetings that everybody gets to review, make any sort of adjustments or recommendations, and then finally agree upon. And this IEP document gets reviewed yearly by the team and by the parents or caregivers. One helpful tip for IEP meetings is that you can bring an advocate with you. So that can be a friend, a family member, somebody who's knowledgeable about these things. They can help you take notes and help you kind of express your concerns about your child's learning. The 504 plan comes from the Section 504 of the Rehabilitation Act. And this covers children with any kind of disability or health-related condition. So to qualify for a 504 plan, the child doesn't necessarily need to have ADHD or learning disability. Epilepsy by itself qualifies a child for a 504 plan. And these are sort of less structured, less codified guidelines about how to help children with disabilities or health-related conditions succeed in school. So some examples of accommodations, modifications to the curriculum or interventions that can be helpful to children with IEPs or 504 plans include getting additional help with organization. So this may be giving children their assignments in a different way that's easier for them to keep track of, either having an electronic calendar or like a big calendar in their backpack that's easy for them to look at and know what they're supposed to be doing and know what they're supposed to be working on. It may include extra time to complete tests or assignments. It may include arranging the student's schedule so that harder classes occur at times of the day when the student is most focused. So if a student takes some medications and is really kind of sleepy in the morning after that morning dose of medications, maybe put the easier classes in the morning and the harder classes, at the time of the day when they have the most focus. It may decrease the group size that they're working with to make it easier for them to focus. And there may be alternative formats. So if somebody has difficulty with reading or with visual processing, they may get their information from an audiobook, or they may have assignments read out loud to them, or get audio recordings of the lectures. And another important consideration in epilepsy is if children have breakthrough seizures, or they have frequent doctor's appointments, or they have to get admitted to the epilepsy monitoring unit to get a video EEG, they may end up missing more school than their peers. And so a 504 plan or an IEP may include some adjustment of what the expectation of a student is to make up their assignments that are missed due to their epilepsy. Other interventions include tutoring, school-based speech therapy, developmental therapy, occupational therapy, physical therapy, applied behavioral analysis, which is specific for autism, or counseling within the school setting. All right, and so kind of shifting gears now to how to manage seizures in school, because that can really impact how comfortable a child feels at school, how their peers view them, and of course their overall safety, and again how the teachers and the school staff react to the child. So we'll talk a little bit about seizure first aid and preventing injuries, seizure action plans, communicating with your school staff. The Epilepsy Foundation has seizure training for school personnel and school nurses. So if that's something you think that your school would benefit from, you can talk with your school nurse or administration about getting that set up for the school nurses and school personnel. And then I'll touch on the Illinois Seizure Smart Schools Act, which recently passed. So seizure safety, most of you are probably pretty familiar with this by now. It varies very much on the type of seizure that a child has. So if a child's having kind of the classic generalized convulsive or generalized tonic-clonic seizure, the best thing to do is help the child get safely down to the ground, get the child on their side so that any saliva can flow out of their mouth. Never put anything in the child's mouth, and kind of clear the area so that they can't hurt themselves on anything. And then try and shoo bystanders away, but get someone to get help, time the seizure, and then use the rescue medications as prescribed for that child. Call 911 if the seizure doesn't stop after 5 minutes, or if you use the rescue medication and the seizure doesn't stop, or if the child's not waking up as expected after a seizure. Less severe seizures may require a more or a less aggressive first aid plan. So if somebody's having absence seizures, or they're having a small focal seizure that maybe only involves some motor activity in part of their body, or impaired awareness, where they're not actually convulsing, the first aid for that starts with recognizing that the child's having a seizure, keeping track of the seizures, timing it again if it goes on for 5 minutes, or if it meets a certain time point outlined in the student's seizure action plan, giving rescue medications, and watching for seizure cessation. And if the seizures don't stop with intervention, then following the seizure action plan to either contact the parents or call 911 or EMS. So here we have an example of a seizure action plan. This one is from the Epilepsy Foundation website. There are other versions of this, and the key components of a seizure action plan include a description of the types of seizures a student has, what their triggers might be, what restrictions they may have from activities. Can they participate in different sports? Can they swim? Do they need like a one-on-one aid, kind of the whole spectrum there. What their rescue medications are. So that do they have rectal diastat? Do they have an intranasal midazolam? Do they have a vagus nerve stimulator where the magnet needs to be swiped? And then the seizure action plan will also have the emergency contact info. So how to get in touch with parents, how to get in touch with the caregiver, if the parent's not reachable, and how to get in touch with the doctors. So the Illinois Seizure Smart School Act went into effect on July 1st of 2020. And so this requires all school personnel in Illinois to be trained, all schools to have personnel that are trained in seizure first aid, and all students with epilepsy to have a seizure action plan. So this is something that we're really excited about, that will hopefully result in more comfort in teaching students with epilepsy at all schools in Illinois, and more appropriate responses to seizures when they do happen in school, both for children with epilepsy and for children who don't already have a diagnosis of epilepsy but have their first seizure in school. So I'll stop here. I'll leave up these resources, and we can get to the questions and answers.
Awesome. Thank you. There are definitely some questions that have come through the chat. I will read them. So at the 6:17 mark, and you're welcome to also take a peek. The question is, can ADHD remain even after seizures stop?
Yes. Yeah. So this gets back to, are the seizures the cause of the learning disabilities or the ADHD, or is it the underlying cause? So very often with ADHD, it seems to be kind of an independent, like bedfellow with epilepsy. And so especially if your ADHD started before your seizures, it's likely to continue even after the seizures are controlled. And that kind of brings another point to mind. So a lot of ADHD medications, particularly the stimulants, will have the precaution that they can provoke seizures. In practice, we have many patients with epilepsy and ADHD who are on stimulants like Ritalin or Adderall, and we don't seem to see that in practice where this ADHD medications cause seizures. One medication that we do see more often provoking seizures is Wellbutrin. I don't think people prescribe that very much for children these days. I don't see it in very many of my patients, but that's just something to keep in mind.
Okay, thank you. The next question, if seizures are under control, but the EEG is still abnormal, are there impacts on learning or behavior caused by those abnormal spikes?
Yeah, so that's a really interesting question and something that actually comes up a lot in practice. So we get the seizures under control, but we get the follow-up EEG and there are still spikes. And so what we look for on the EEG are those kind of red flags where we see that the spikes are just continuous in sleep. So when the child falls asleep, the spikes, appear and they're there all night, and we don't see the normal sleep brainwave activity. Or in the example I gave where the child falls asleep and we see actually the brainwave activity kind of shut down for a second or two at a time during sleep. If we see that, then that is a red flag that the abnormal brainwave activity is continuing to cause some cognitive problems. The other side of that is we may see spikes, but if we don't see those red flag symptoms, then there's much less of a chance that it's the spikes that are causing cognitive problems. If you're in that boat where you have your follow-up with your doctor and we still see spikes on the EEG, we're still struggling in school, but the seizures are under control, then you want to go back and look at what other things can be contributing. Are there mood problems? Is there untreated ADHD? Or is there anything that we can do with the medication? Could it be a medication side effect? If you still think it could be the spikes, then I'll often try seizure medication and see if treating the spikes results in improvement. But what I always say is we need to have something measurable. So we need to have a pre-test and a post-test. So the gold standard of that is doing neuropsychological testing. So get that at baseline and then retest again after we've treated the EEG or controlled all the spikes. And if we do see an improvement, then that lets us know that getting those spikes under control is likely the cause of the improvement. And if we don't, then it's not likely that the spikes, or if there is an improvement on the medications that are controlling spikes, then it's probably not the spikes themselves that are causing the cognitive issues. I hope that answers your question. If it's not clear, I can try and clarify.
That's awesome. Your presentation, I can see from the chat, has been very, very well received, and your explanation of learning disability with epilepsy it's really great. I've not heard it this way either, and so I'm learning so much. And Laura had asked a question just right before you were transitioning to the school section, and so Laura, I just want to ask you if Dr. Henry answered your question about how to bring this conversation to the school, or would you like additional clarification on that? So if you wanted to unmute yourself, if you're still around, and let us know.
Yeah, I'm here. I do think I understand that there's ways to get information to the school and training using the Epilepsy Foundation. However, it's been a year now, and it's just difficult because I still get phone calls every day, and they're looking for more explanation on why things are happening. And even though all the resources are in place, it's just difficult, and I didn't know what more I could do to help them.
Yeah, so it's not uncommon that you may have an IEP or a 504 set up and you've got your seizure action plan, but things still aren't kind of going to plan, or there's still bumps in the road. Do you mean more that your child's having seizures and they're you feel like they're not being the seizures aren't being addressed properly, or is it more like the academic educational issues?
No, I think it's more the academic and behavioral, and understanding that there's, like we said, the web, like there's all these different things that are part of it, a piece of it.
Mm-hmm. Yeah, I that can be a challenge. You can call an IEP meeting at any time, like that's your prerogative. You don't have to wait to the 1 year mark. I do hear from families who say, I've got the 504 and the 504 plan has everything that I want, but the 504 is just not always followed. Schools are, legally obligated to follow the IEPs. And so if you think that, it's like a more, they're just not following the IEP even after you've addressed it and had some mediation. There are some legal resources. I've typed in the Illinois legal aid. So if you think it's more of a issue, they know what's in the IEP, they just aren't doing it. But kind of a step before that is recalling the IEP meeting and meeting with the staff that originally made it. Getting collateral information from your doctor can be helpful. There are also independent advocates who can be helpful for you in having those conversations. So, bringing the clinic note or having a letter from your doctor kind of explaining how these things are interconnected in your student and how they affect learning might help. I hope that helps.
Yes, thank you.
Also, the Epilepsy Foundation, our case managers are able to come out with you to your IEP meetings as well as your advocates.
Oh yeah, that's even better. Yeah.
Then I can help to amplify Dr. Henry's message, or not I myself, but our case managers. And thank you for mentioning the Seizure Smart School Act. That was a real big win for us in writing that a couple of years ago. And one of the big components of that we made mandatory was the seizure action plan, because we were finding that there was just so many gaps in the information chain, and creating that simple document simplified everything. So as much information as parents and caregivers can put on that form in conjunction with your physician, I think that is really, really helpful for the school.
And I also want to highlight this website here. Actually, I didn't know about it until I was doing my research for this talk. It's called understood.org. And it's just a really rich informational website about disabilities of all kinds. And there's a nice section on students and disabilities in the school setting, and lots of kind of easy to understand information on IEPs and 504 plans, including like videos, and how to approach your school when things aren't going well.
There are two more questions that came through. One is, do you see issues with Depakote in learning or behavior?
Yeah, so Depakote can be one of the more sedating medications. It can affect kind of cognition long-term when we see people who are taking Depakote for like 30, 40 years. It can have like a long-term impact. And mood and behavior can go either way with Depakote. So sometimes it helps mood and behavior, sometimes it makes it worse. And it's hard to predict in any individual child, what you're gonna get. So you just kind of have to try it, stick with it for a little while to see. and then, adjust it as necessary until you find, the right combinations of medications that's going to control the seizures, but, have tolerable side effects or no side effects.
Yeah, sometimes it's just it's a time game to figure out what's the right balance, what's the right medication. It can definitely take some time. And on that note, so seizure freedom being the ultimate goal, if we are one step close to that in getting seizure control and kind of weaning off medication, is it still necessary for a parent to have the 504 plan with that school? Do you think that that is still something to keep in the back pocket?
Yeah, and I think so. And it's very much up to the individual student and family. So, very often, like the ADHD, the learning problems may persist independently of seizures and be there after remission. And so that 504 plan may still, really help the child in school. But that's up to you. I've had some families feel uncomfortable with maintaining the 504 plan because they don't want the child to be seen differently or treated differently. They're worried about the stigma. And if they're doing okay in school, um, that may be an appropriate decision for them. One thing to note is that you can carry 504 plans into college. So just because you're smart enough and independent enough to go off to college, doesn't mean that you don't also need some extra help to succeed. And so people who do qualify for 504 plans and IEPs can continue to have those in college.
So Dr. Henry, where can people find you? Your clinic? You can give us that info.
Yeah, so I'm based out at the University of Chicago, and the main clinic is at Comer Children's Hospital in Hyde Park. I have a clinic in the South Loop. So if you're familiar with the area, it's above the Whole Foods on Canal Street. And I also come to clinic twice a month in Maryville, Indiana. And so let's see, for appointments, our appointment line, I'll just throw that number out there, is 773-702-6169. And we have myself as a pediatric epilepsy specialist. There are 3 other pediatric epilepsy specialists in our group. And in total, we have 9 neurologists and 3 pediatric neurology nurse practitioners. And we do kind of go all over Chicago.
And do you also have the neuropsych testing on site as well?
We do. We do have neuropsychological testing at the University of Chicago. You can kind of Google that and see that section. Neuropsychological testing in general does require a referral. You can either get that from your pediatrician, you can get it from your neurologist, but it does require a referral. It's not always covered by insurance, and different clinics will take different insurance. So you may kind of need to call around until you find somebody that takes your insurance.
Makes sense. But I do agree it's a very important component to all of this. So I think that's something that we should really work to get our kids tested.
Mm-hmm. Yeah, it takes a lot of patience. The wait list is quite long to get into a neuropsychologist. The same for developmental pediatricians. I didn't mention that specialty in this talk, but it's actually a really helpful specialty for children with epilepsy, children with autism. These are pediatricians who have fellowship training specifically in childhood development, behavior, and learning, and can be a really great resource. They're also scarce, but if you can get in to see a developmental pediatrician, that can also be a great source of help. And we have
Is testing something that should be done on an annual basis, maybe just to kind of update the 504 or along the way?
Yeah. So it's really more on an as needed basis. So if everything's, stable, if the student's making good progress, you may not need it every year. But if there's a change, that we're seeing some regression or plateau, or the epilepsy is getting worse, that may be a reason to redo the testing sooner.
Well, thank you again for your time tonight. I know this was very, very informative. Lots of good information tonight.
You're welcome. Thanks so much for inviting me. This was it was fun to be able to get to talk directly to families get talk directly to the community about this topic.
Yeah, fabulous. Thank you everyone for tuning in, and we'll have another virtual chat next month. So thank you all and have a great night. And then this will be on our YouTube page, so you can watch this a little bit later as well.